Pilar Schiavo, I'm going to first introduce myself and then turn it over to her. My name is Michael Leidy. I'm the president of Healthy California Now, and really want to thank everybody for joining. We have an extraordinary opportunity to talk with one of the foremost experts on single payer in the country, health economist and Dr. James Kahn from UCSF, emeritus. And before we get into Jim's talk, and we'll have an opportunity for Q&A, I just wanted to introduce Pilar Schiavo, who is the organizer for Healthy California Now, to give a pitch on what we're up to. Pilar?
Hi, everybody. And Jenny can jump in here. She's been leading, along with local folks in Los Angeles, work to organize the big event that's happening on July 31st in Los Angeles. So a lot of folks know, you've been around long enough to know that many years we have had events and actions around Medicare's birthday at the end of July to kind of commemorate the original promise of Medicare, that it would be expanded to all. And then this year, because of COVID, there's an emphasis on folks who have been impacted by COVID and impacted generally by lack of access to healthcare. And so because of that, we are doing an event on the 31st. We're doing a statewide day of action. The big event is happening in LA, which I'll let Jenny say a few words about. And then we also have events that are happening in Oakland and San Francisco, San Rafael, Chico, and I think that's everyone, but if I'm missing anything, jump in. We're going to be sending out emails if you're on our email list tomorrow with details about it. And I'm just going to share my screen really quickly to show the image that Jenny created, which is so beautiful, to give folks a sense of kind of our message and details about the locations of the bigger events. We have a number of sponsors for the event, which is wonderful. There's going to be an opportunity to do kind of a memorial commemoration of loved ones who have been lost. And so people who come, we're asking if you can wear black and you can bring a memory, something to remember a loved one lost either due to COVID or lack of healthcare. And we'll have, different ways to participate at the different locations. We're also going to be doing a Zoom event. And so we will have an opportunity for people to join remotely if you are staying safe and distanced, or if you're just not in one of the areas where an event is happening, you can still join, and Michael's going to be anchoring that event. So we'll hear a lot of the speakers and kind of show live what's happening in LA, and then we'll check in from different locations where we have events happening as well. So I will share in the chat some of the details. If we have a Facebook event, we have a tweet that people can share and get details on. And then if you're not on our email list for some reason, please go to healthyca.org and sign up, and you will get an email tomorrow morning about this as well. And Jenny, do you want to highlight a few of the speakers and some of the special stuff that's happening in LA?
Sure. In LA, we're wearing all black. Because we're remembering those who were lost to COVID-19 and lack of healthcare. We will bring tokens to remember those we've lost. Like I'm going to bring a picture of my father, who I lost just before the pandemic. And like Pilar said, we're recognizing the unfulfilled promise of Medicare, because it was originally a vision intended to cover everybody. And definitely, we're going to call on Governor Newsom to deliver on state single payer. And that's the main focus. We want this not just be an event outside of his office, but we're going to take portraits, put a package together. And, similarly with the rally that we did in Sacramento, there was participation from the staffer who didn't just meet the activists, but also spoke at the rally. And, we know the governor sent a letter, in May. That's not the letter we wanted. HCN, has spoken with the governor and in writing has critiqued that letter that we want single payer, has made that very clear, and continues to call on the governor that we want to work in partnership to get him there, and offer support through the recall. So wear black, bring tokens of remembrance, and please share the event. That's the big thing. We want to make sure turnout is strong. Thank you. Oh, some of the speakers. 1 second, let me pull up that spreadsheet. We have a lot of community speakers. We have someone from UTLA joining, Filipino Worker Center. We have a lot of organizations that we haven't seen in the movement yet. We have an endorsement from James Lawson Institute, Civic Sundays here in Glendale, a giant group called Momtivist, which is a group of mom activists. They've endorsed and are sending a speaker. Move to Amend has endorsed, and we're just trying the best we can to expand the movement, because at this point, there's very little argument against single payer. Even when I go into retiree groups where there's a collective of different union members, delegates, I used to get resistance, bringing in a flyer like this. No, not anymore. There's maybe one person who contests, and we get the endorsement. It's a different time, and people want it. We don't have to sell it. And the poll numbers show that as well. So please help with turnout. We need to make the most of these events. They help the governor feel confident, and that he can do it with our backing.
Thank you. Yeah, LA, I think, is going to be a really great event. If folks are in the area, please join. So that's the plan. I put everything in the chat for folks to grab that. You can also find it on our Facebook and our Twitter. And like I said, we'll be sending it out tomorrow. And if you're not on our email list, please go to healthyca.org and join that. And we hope that you can participate if there's an event in your area, or join on Zoom. I'll also drop the Zoom RSVP into the chat so people can just do that directly. And we can go ahead and get on with the program that everyone's here to see today. And thank you, Jim, for joining us.
All right. Thank you, Pilar. Thank you, Jenny. So Dr. James G. Kahn, MD, is a MPH, is a renowned professor emeritus in the Department of Epidemiology and Biostatistics and the Philip R. Lee Institute for Health Policy at UCSF. Jim is a health economist who's been publishing studies that detail the cost savings of a single payer system. And in January 2020, he announced a comprehensive study, and he organized and led a day-long conference called Medicare for All: How to Do It Right. And that conference brought in many US and international experts. So it's our great pleasure to welcome Jim Kahn. Thanks a lot, Jim.
Thanks for inviting me, Michael. And I want to start by saying that, Jenny, the report you gave on the shifting response that you're perceiving about single payer is music to my ears. We've been in this battle in California since at least 1994. And, moving the needle in a meaningful way has always been a challenge. And it's really, it's heartening to hear that more people know what it is and want it. So, Michael, did you want me to start with a discussion of what single payer is? Is that right?
Yeah, just if you could identify, kind of from your perspective, the key elements that really define single payer.
Sure. I've been thinking about it a lot. And as Michael knows, I recently had the unfortunate experience of submitting an academic article to a medical journal about single payer, and having the editorial staff at the journal reply that there is no such thing as single payer. That was their response to me and my co-author, who's a national figure in the single payer politics. And it's just kind of crazy. Single payer is a thing, and it really most fundamentally means that we replace our tremendous profusion of payers for healthcare with one government payer. Why does it matter that we have so many different healthcare payers? It matters because of the complexity and confusion and bizarre incentives that it introduces. At one point some years ago, we counted the number of just public funding streams for healthcare in California, came up with 63. different public funding streams in California. And that didn't even count the scores of private companies and plans. And each of these insurance channels has different sets of rules about, of course, who's covered, but also what's covered, under what conditions, for what amount of money. And this introduces extraordinary cost to the system, probably at this point over $900 billion a year in the United States, as well as great confusion and frustration. In addition, some of the insurers in the system, many of them, both on the private side and increasingly on the publicly funded side, are private for-profit insurers. So on the public side, of course, that's Medicaid managed care and Medicare Advantage. And so you have these for-profit companies. Obviously, they're trying to maximize their profits, and the techniques that they use to accomplish that put financial burdens on patients. And when patients have financial burdens, they delay or forego care. And when they delay or forego care, they get sicker and they may die. The estimates vary, but probably in the range of 70,000 to 80,000 deaths per year come from lacking insurance or being underinsured. And the numbers may go up as we study more and more about the effects of increasing deductibles. So all of this confusion wastes a lot of money and kills people. So single payer would take all of these different funding streams, take all of the money that's currently spent on public programs, Medicaid, Medicare, Veterans Administration, et cetera, put it all into one government pot, and then raise taxes to collect the money that's currently being spent for private insurance premiums and out-of-pocket costs. Those premiums and out-of-pocket costs will no longer be imposed on families. So instead, they'd pay taxes, would be progressively financed. That money would come into the government. So all of the money needed to run the healthcare system would be in one place. And that would lead to savings of on the order of $750 to $800 billion a year nationwide. That money would then be used to do two things: insure the uninsured and properly insure the underinsured, people with high deductibles and high other kinds of cost sharing. The net result on the budget, and this comes in part from a paper that we published last year in PLOS Medicine, the net result would be a savings of probably 5 to 8%. The number we reported back then was a little bit lower, but we subsequently done some more work, and we realized that with the latest data on what happens when you shift to a single payer system, that we're talking about minimum 5% savings. So you cover everyone by simplifying the process, and you save so much money that you can put money in the bank, or you can use it for other important needs, like expanding payments for long-term care, both institutional and at home. So that's what single payer is. There's some other features that I want to mention that are shared with essentially all of the wealthy countries, what are countries in the Organization for Economic Cooperation and Development, or the OECD. We're studying the core features of those insurance systems, and the core features, the main ones are: number one, everyone is covered. Number two, they're covered with exactly the same basic coverage, basic comprehensive coverage. Number three, that coverage is sold by not for-profit insurers or the government. Most countries, it's the government. Some countries, it's not-for-profit insurers. That's completely different than here in this country. And if for those of you who are clinicians and may care about this, every doctor sees only one payer. Every doctor sees only one drug formulary.
Turn the volume down.
What? How did you get rid? It used to be all the whole
Mom.
screen.
He doesn't hear us.
Oh, I do. I can hear you. I hear everything. So there are some features. It comes out to about 7 or 8 different features of all of these other countries. All of these other countries which have better longevity than us and better control on costs. And if we want to succeed like these other countries have in paying for paying for healthcare, then we need to imitate what they all do. And the best way that we can imitate what they do is to have a single payer system. So I'll stop there, see if there's any questions about that.
Yeah, I'll start, Jim, and other folks, put your question in the chat or use the raise hand function. When you say not-for-profit insurance companies, it's also true that they do not control or generate net income for private capital budgets. Is that the case?
Good point. And one of those core features, which I didn't list yet, is that the decisions about investments, capital investments like new hospitals, are made under the control of the regulatory authority. So there's no point in getting the operating surplus because as a business tactic, but the money is either has to be approved to be spent for that purpose by the regulatory agency, or the money actually comes from the government.
All right, and we have a question I wanted to raise as well. Someone asked, I would love to hear information about reimbursement for providers, including non-physicians, physical therapy and so forth. And that goes to the question I had, which is a lot of the debate you hear is between, say, fee-for-service or per capita payments. And that's really separate from global budgets. There's a great deal of in the advocacy community, a great deal of consensus around global budgets, say for hospitals, but more debate over the virtues of fee-for-service versus per capita for providers, and who is considered a provider, say, physical therapists, acupuncturists, and so forth. So could you comment on those set of issues?
Well, sure. Any provider group or class, like physical therapists, will have a mechanism to be paid, and then will negotiate the rates that they'll get paid. The big issue that comes up regularly between capitation and fee-for-service is something on which I decidedly have no opinion. Let me explain. Neither one's perfect. Fee-for-service has the potential to encourage excess use. Capitation has the potential to lead to denying useful care by trying to stay within the capitation budgets. Both can fail, both can work with the right incentives in place. For example, you don't want a capitated system to be owned and operated by a for-profit, shareholder-driven organization. So if you prohibit the worst excesses of capitation, then you can have capitation work quite well. And one of the things we discovered in studying these 32 countries in the OECD is that there's no consistent pattern. Some of them have just fee-for-service, some of them have just capitation, and a few have both. And all of them work okay. They work fine. So I get exercised about people getting exercised about fee-for-service or capitation. I think it's the wrong issue. I think the right issue is to keep the focus on a simple payment system, keep the focus on clinical care, make sure that all appropriate clinical provider groups are included in the system. And then that's the basis for doing health insurance right.
So essentially the primacy of professional clinical judgment as a basis for care decision-making?
In the queue. Can you?
Absolutely, the primacy of professional clinical judgment. I will say that, I'm a health services researcher of 3 decades duration. And I do think you can, using the good kind of data we'll have from single payer, we'll have universal, clean, consistent, rapidly available encounter data. So every time someone goes into the doctor, whether it's capitated or fee for service, there'll be a record of that visit. And those data sets will allow us to look for outlying patterns that may represent bad decisions, but systematically bad decisions by clinicians. So if one office is doing a kind of procedure that is rarely appropriate repeatedly, that might be an indication that they're abusing the system. And you have the ability to look for abuse or fraud in that way. So it's not like, in my view, every single doctor should be able to do whatever they want. But in general, yes, the clinical situation, the doctor and the patient should be that should be the focus.
All right, we have two questions. One just on capitation. You're essentially referring to a payment from the single payer system on a per person basis, or sometimes it's on a per case basis. Would that be fair to say?
Well, capitation is a per person month,
Yeah.
not per case. There are systems that have been proposed and that have been tried that are based on a per case basis. So if someone has a particular heart problem, then there's a certain fixed payment for all of their inpatient and outpatient care for a period of time. I cannot claim to have closely looked at that evidence. What I have seen so far, it's not encouraging that that's a substitute for these for capitation and fee for service. But under a single payer system, you could consider that. Wouldn't be the first thing I would do, but again, I think payment mechanisms are probably more flexible than other aspects of the single payer.
One of the questions was, there's a difference in single payer type systems, say between the National Health Service in the United Kingdom versus the Canadian Medicare.
Oh, well, there are indeed. There are a lot of differences. For example, do the doctors work for the system? The NHS, traditionally the doctors have worked for the National Health Service at least part-time. And in Canada, they don't. Canada is a national health insurance mechanism where the doctors, well, there are some public doctors, but on the whole, doctors are privately employed and get paid by the government. So there are differences like that. Again, it can work both ways. There are plenty of countries where doctors work for the government, and there are other countries where they work for themselves. The key thing is to have a payment mechanism that is simple for each doctor. And some of those doctors are salaried, and that's a perfectly fine way to get paid.
So we have some questions about mental health and its inclusion in a single payer system.
Yeah, we're not in favor of mental health. We'll exclude that. Just let all the people with depression and schizophrenia suffer. No, I mean, seriously, of course, mental health is a central part of medical care. There may need to be decisions about some types of care that are, subject to judgment about whether they're considered to be part of the medical care system versus other kinds of services. I happen to have a 22-year-old son whose mental health is greatly enhanced by a mindfulness meditation. So if you ask me, we'd be fools not to have a broad definition of what constitutes mental health care.
All right. Question about oversight. What kind of oversight will be built into this paradigm, in terms of transparency and accountability? She also asked, is someone working on that, which is probably beyond, in terms of the specifics in California, what you're working on, but just in general, what have you seen in terms of these common characteristics of national systems where oversight's effective?
Right. So we haven't delved into the OECD oversight mechanism. I can tell you that as you know, Michael, in the United States, when we've had single payer proposals, there have been governing mechanisms that have representatives from the provider community, from the consumer community, typically from other important groups like unions and businesses, in an attempt to have the direction of the system driven by a highly broadly representative group of people. and then for the overall, say, healthcare commission. And then there are other committees which or commissions, subcommissions, which look at issues like quality of care and so on, and those also have relatively broad representation. I'm not a political scientist. I know there's an issue of capture of these regulatory entities that have to be really carefully considered. Out of my scope, more in Michael's. So if you want to comment on that, Michael.
Well, I want to make sure you get an opportunity to address folks' question. We mentioned briefly global budgeting, but there was a question about your view on that, since we didn't dive into it. Yeah.
So most systems have hospital global budgets. I think you mentioned that earlier, and that is in the US single payer plans in general. And then there can be a system-wide budget as well, which will say that in the next year, we will pay up to this much for all our healthcare spending. In order to do that effectively, there need to be mechanisms to discourage utilization in the event that it looks like we're headed for an overage. There are reserve funds that can help. There are mechanisms to decrease compensation. I would predict that there will be battles toward the end of fiscal years as money looks like it might be tight. Those battles will be relatively public and transparent. And there will be decisions, sometimes tough decisions to make about whether to postpone certain kinds of elective care. People will win parts of the battle, lose parts of the battle. Right now, all of that is obscure. It's completely hidden. And all of the decisions about what to cover and what not to cover are driven by people who have a personal stake in what happens. Whereas this would be a much more open process, not without distress, but much more likely to produce reasonable solutions.
What do you think would happen to these investor-owned hospitals, or what do you think should happen under single payer? If we go to those global budgets, it seems unlikely the system is going to want to pay for their profits.
Right. One scheme that has been put forward, and I haven't analyzed it myself, but my colleagues have, would be to simply buy out the hospitals. It's a one-time substantial expenditure, but would make all of the hospitals then into not-for-profit. I can't, again, I haven't done the work myself, but my colleagues tell me that it is, while it's a big amount of money, it's within reach. Remember, our healthcare system spans almost 20% of the economy. And the amount that we would save, if it is just 5% of that per year, is 1% of the economy. And that allows us some leeway to do things like buy out hospitals. Also retrain workers, of course.
Right. I think I think it's fair to say that under single payer, all those ads on TV promoting private Medicare plans would go away, and we would all be relieved with that. We're also getting a question about the transition and, just maybe a definition of what you mean by doing single payer the right way, as that conference addressed, and what do you see as the best transition path, if you have a view on how to get from here to there?
Well, there's considerable debate that I've been part of about whether we should try to move extremely quickly or try to blunt the change with a slower transition. The argument for quick is that orchestrating a successful transition can be challenging. That there will be groups that continue to oppose the transformation and will attempt to undermine it, to attempt to change the law after a year or two, and that we're better off doing it extremely quickly. I would say on the financing side, to the extent that the financing plan affects how different groups do, there may be a good argument for a several year transition. For example, on the side of companies that will may be asked to pay a payroll tax, for the companies that currently aren't paying anything for insurance, for health insurance, maybe they would have 3 years to come up to the average. Maybe the companies that are already paying a lot would have 3 years to come down to the average. So that would be a reasonable negotiating point about, as long as you have the money to run the system, how quickly should that burden shift. I think also for hospitals that would be expected to start to operate differently, for example, to go to a global budget that removes any money that was previously used toward operating margins, maybe that would happen over a couple of years. That's a reasonable discussion. I think I do worry about long-term plans, when someone says, well, let's just do this over 10 years, because all that is 10 years of fights to try to, upset this. If we get to the point where we're about to win single payer, let's do it quickly. It certainly was done quickly in Taiwan, for example, very quickly. And there's no, with adequate preparation, I don't see any technical reason why we couldn't move rapidly.
All right, I tend to agree with you. This is the quicker the better. Some folks are asking about the relationship between single payer and Medicare. I don't know if you've looked at that. How much Medicare could be integrated into a state system, and also just how vulnerable California would be to a change in administration. If we get the waiver and the federal support, could that be withdrawn?
Well, as you know, everyone probably is aware, there's a big debate in the single payer advocacy community about whether we must go federal, national, versus whether we should start with the states where we can get this done. This is the second issue today on which I will express my firm agnosticism. I don't know. It seems to me that if Gavin Newsom does the right thing and endorses single payer and really wants it to move forward, are we really going to say no in the advocacy community? It seems unlikely. Now, in order for single payer to operate really like single payer, we do need to fold in a lot of programs, particularly federal programs, particularly the Medicare money. So I think it will be really important, in order to do a decent version of single payer, that we not come up with some lame and illogical version where we say, well, by single payer, what we mean is all of the private insurance and Medicaid. And we don't really mean Medicare, we don't mean the VA, we don't mean this, we don't mean that. Well, then that's not really single payer, so then it's not really a proper test. As I've said, politics is not within my scope, and so what's involved in getting the Biden administration to truly support a California single payer effort, I can't say, but I can say if it is a reasonable approximation of single payer, then with the folding in of federal funds from Medicare and Medicaid, at least, and the VA and the federal private insurance for federal employees as well, if it really looks like single payer at the state level, I just can't see saying no.
Yeah, I would just add that Governor Shumlin from Vermont made some very positive remarks at the latest Healthy California for All Commission meeting last Thursday, where he had a take on it that said, if California really moves toward implementing single payer, like it is happening in California, his view is that Democrats in Congress would be compelled to do it for the entire country. And given the significance of California and the political momentum that would represent. So that's another take, from someone who's obviously been in the trenches. So,
Right.
and I think the other example relevant to this question is the Affordable Care Act. Yeah, it was very unpopular, but then it became very popular, and it became so popular that the Republicans couldn't repeal it. And that is what we know about healthcare, is that when people get something that's substantially better than what they have, they tend to defend it. And it become politically difficult, if not impossible, to undo. The Tories, they undermine the NHS in the UK, but they never take it on head on, right? And so there are lots of different kinds of fights we may end up having, even, with a system though that remains, intact. And so I do think we ought to pay attention to what it's going to take to enforce the winning of a single payer system. But I think you're right, Jim. That ends up being a political question.
And I would say that, defending the ACA, you're right about the ACA, but remember, it was a thumb up or thumb down that determined the non-revoking of the Affordable Care Act. Thank John McCain at 1 o'clock in the morning.
Yeah.
I hope that with single payer, the level of support is gives us a little bit more margin for safety in that regard.
I think you're right. Well, so the question is asked, if you could be in charge of the Healthy California Commission, what would your direction be? Because you kind of suggested it, right? That it's a very robust version of true single payer. But would you add anything to that?
Right. I think I would make sure to look at those core European features and not bend on those. So for example, some of my colleagues who are less to the left than I am have said, well, what about Medicare Advantage for all? And my answer is no, because the way Medicare Advantage works, and the Kaiser Family Foundation just published some really important polling on this, about the financial burden imposed by Medicare Advantage. The way Medicare Advantage works is that private for-profit insurers use various techniques, including restrictive provider networks, misrepresentation of who's in those provider networks, and other techniques to personally profit. Do we really want to hand, when they're on the brink of victory with single payer, do we really want to hand the victory to the private insurers? I don't think so. So we need to, but then, as I said, on other issues like capitation, I'm much more tolerant of that as part of it. And I know there are quite a few single payer advocates who believe that capitation in any form is a disaster, and I don't believe that. So there are going to be a lot of highly detailed conversations with different points of views expressed. But I think if we have a list of the critical features that we cannot bend on, that's where we can keep referring back to that. I say, well, why don't we do it this way? I say, no, well, actually, no other country does it that way. What makes you think the California can do it that way if no other country's ever done it that way? And try to, as a health policy analyst, is a big part of my identity. I like to believe that we can learn from health policy evidence. It's not always easy, but I continue to hope that, if 32 countries have done it this way, maybe we shouldn't do it this way, particularly not when we're trying to change and become more like them.
Your clarity is deeply refreshing. Thank you, Jim. But along those lines, is there a non-scholarly source for information if people want to know more about these other national healthcare systems?
So non-scholarly, well, there are big reports produced by the European Commission and by the OECD. Tom Rice, who's a colleague at UCLA, just came out with a report of about a dozen of these countries. So I'm sure, I haven't read it yet, but I know Tom's work, and he's a excellent writer. You could take a look at that. Our own work we hope to have out. It will be scholarly though. Sorry about that. We will have it out. It will have the advantage of being short. because of the way these articles work, we'll be in the range of 4,000 or 5,000 words. And so I would like to propose that for people who are interested, that will be a good place to start.
All right. So you're asked to outline your preferred financing mechanism for California single payer. What percentage payroll tax? Do you like a value added or gross receipts? Do you have a view on the specific financing provision?
So I have a grad student who's working on this right now at the federal level, but I think the structure is the same. And it looks to us right now that a system that combines payroll tax with 3 other kinds of taxes has the best potential to first produce enough money, which at the federal level is probably about $1.3 trillion per year, and to do so progressively, meaning the burden is on people who are higher income and higher wealth. And so a modest payroll tax, a few percent, like 3 or 4%, combined with a very progressive tax on all types of income, including salary and wages. So again, people who earn, say, over 120,000 would take all or the biggest chunk of that. And secondly, a tax on capital gains, which are already upwardly skewed, because who gets capital gains is rich people, and to tax that. And then the third is a wealth tax. And certainly wealth tax has been talked about in other contexts. And due to the great work of people at UC Berkeley and elsewhere, we know that there's plenty of wealth to be taxed, and the wealthy are getting wealthier really fast. So no matter how much we tax them, they're still going to get wealthier. So we shouldn't feel bad. Of course, there are political issues, but I do think a multi-pronged taxation strategy where you can understand the progressivity, it's really important. The reason I say that is I'm not a fan of the gross receipts tax. When this came out as an analysis of the California bill, I looked into it as best I could. And the fact is, it's hard to know who's paying it. Is it suppliers? Is it the owner of the company that's selling the goods? Is it the customers? It's really hard to figure out. And it's definitely not easy to make it progressive. So I think it's kind of a strategy to be avoided. We should tax in ways that we understand what's going on. So again, for me, that's payroll, income of all sorts, capital gains. Earned income of all sorts, capital gains, and then wealth.
All right, fantastic. Have you looked at this question of transition for affected workers who are displaced by moving away from this complex administrative system of multi-plans to single payer? Because that's where a huge chunk of the savings comes from, of course, is no longer having to pay folks to process claims and deny care.
Indeed. And that is a big chunk of the savings. So I haven't personally looked at it, but I have looked at the work that Bob Poland and his colleagues at University of Massachusetts Amherst did on this very question. And what Bob found is that we can, Bob's, by the way, a labor economist. And what he found is that we can spend 1% of the health budget for 3 years, or 3% for 1 year, in order to accomplish several things: to help people retire early, if that's what they want to do, or to retrain them so that they, for example, could go back to clinical work or become a clinician. So the amount of money involved, it's large, but it is totally doable in the context of saving 5% or more per year, to take 1%, 1/5 of those savings and put them toward retraining. The other thing that's really important to remember is if we include long-term care in single payer, both institutional and at-home long-term care, we will need to expand the workforce. So it will be a net job generator. Some of the same people may become long-term care workers, be some different people. The other thing it's really important to remember, we somehow forget in these discussions, is people change jobs all the time. so this is not like a unique instance in the history of the United States that some people would need to change jobs. So we need to support them in that. We need to, very much cushion the blow in a very serious way. But this is, how our economy works. And I find it curious indeed that people on the political right would argue that we shouldn't do something that makes our economy more efficient. I'm mystified by that. We will help these people. The amount of money required to accomplish that is quite manageable.
I think you do see more people on the economic right, shall we say, who recognize the failures of the present system. And I think some of them still hold on to the notion that, well, transparency and more market mechanisms, consumer-driven care and so forth can fix them. That seems to be folly. And I wonder if you had a view on these other, you do see more critique from that wing, but still the solutions tend to somehow fall into similarities with the present system.
Yeah, we have no evidence whatsoever that the kinds of skin in the game strategies that the right, economic right likes to talk about actually effectively control healthcare costs. High deductibles, which is the easiest way to force skin in the game, do keep people from getting care, but that doesn't mean that it controls overall healthcare costs. What it means is those people may spend less on healthcare costs, particularly in the short term. Sometimes they'll get sicker as a result, but in any case, the amount of savings that you can achieve are minuscule compared to where the real money is in our healthcare system, which is in taking care of people in the last year or two of life when their diseases start to be really expensive. Where what makes much more sense is again to revamp the structure of the system. And if I was on a panel some years back with a very prominent neoliberal health economist, someone of more mature years than me, who'd been in the business long before I started, and he was advocating for a skin in the game approach. And I turned to him at a break. I was being too polite, but I waited until we had a break, and I said, "So what's the evidence from other countries that this can work?" And he's like, "Well, there isn't any." And I think it's time for us to admit that that's not it. And if you look at our upcoming paper on the OECD, you will see that high deductibles is not in the core. These countries are mostly not charging deductibles at all. And when they have them, they're a few $100s, not $2,000 or $3,000. So there's no evidence that the way to control healthcare costs is through these economic right strategies.
Excellent. We just had a question. Can you clarify why payroll taxes are not regressive?
So payroll taxes do have the potential to be non-progressive, depending how you structure them. So if it's a straight percent of payroll, it's to my definition, neither progressive nor regressive. If you cap it, then it does have the potential to be regressive. And if you don't charge any payroll tax on the least earning workers and the smallest companies, then it has the potential to be progressive. All of that needs to be tweaked to keep it at least neutral and potentially a little bit progressive. The appeal for me of a payroll tax is that's how we pay for healthcare now. It will be considered the least disruptive if we maintain that element. And as long as we don't have a payroll tax which is substantially regressive, I think it's potentially an acceptable part of a system that is otherwise highly progressive.
All right. We've got someone on the phone who can't put a question in the chat. So go ahead, 415.
Yeah, I just wondered, maybe I missed this, but can this kind of a transition take place with the guarantee that healthcare itself will not be interrupted?
No, we'll have a 2-month vacation for all the doctors and hospitals. Well, of course, we need to set it up so that there's a seamless transition. And remember, you're going from an extraordinarily complex payment system where the doctors' offices are dealing with scores of different payment routes and hospitals with hundreds of different payment routes. And you're switching to one. And for the hospitals, there'll be just a global budget. Excuse me, I'm going to ignore that. My wife will get it. My son's not feeling 100%, but my wife should be answering that phone. And so absolutely, it has to be completely seamless transition. We cannot afford for medical or political reasons to say, well, there's a week when you can't really get care. Call Michael Lighty, he'll help you out.
Yes. Well, I think it's fair to say it's probably easier than transitioning between United Health and Aetna and their different networks.
Well, that's a good point. Again, people change, insurance all the time, and there are other yes.
All right, I think we have another hand up. Brian Stompy.
Thank you. I'm wondering what you think of the University of Massachusetts Perry report that prescribes how California can do this and a projection of $37.5 billion of savings a year, not additional costs, but savings. Can California not just write up something on the order of their plan, or take the Canadian system, which has already been invented in Australia and some other countries? It seems to me we're making, and it is hard work, but it may be harder work than it has to be. We're sort of trying to reinvent the wheel, and the wheel's been invented. The other question is, how do you get politicians who have to say we're going to do this to say they want to do it when it would eliminate the health insurance companies that pass on a good bit of funds to these politicians. They're not working in their own self-interest if they say, yeah, we ought to get rid of these health insurance companies and put that money into healthcare. Thank you.
Brian, thanks for the easy questions. I really appreciate the softballs. Let me start with the second one and say it's above my pay grade how we convince politicians to go against what they perceive to be their self-interest. I mean, it seems to me from talking with people who are more savvy than I about politics, we need to convince them that it is in their interest to support single payer, for example, by threatening with a viable primary loss to them if they don't do that. But otherwise, I defer to Michael and other people who understand politics. In terms of the cost of single payer, the net savings, I mean, that is it could be a much longer discussion. That's something I've thought about a lot in the last 2 years. I know the University of Massachusetts studied very well and worked with Bob Poland on that, helped him a little bit with that. Bob's estimate of roughly 8 to 10% savings is completely plausible. I happen to think he was a little bit optimistic about how much we could save on reducing fraud and unnecessary care. So my estimate might come in a little bit lower. The point is, we looked at 22 studies, and 21 of the 22 or 20 of the 22 found savings in the first year. They were different size savings. Some were a few percent, some were 10, 12%. And all of them, every single one, found savings over time because of the slower rate of growth. So it seems to me that pinning down precisely how much the savings will be and exactly where we'll get them, all of that's not all that important. The goal is to put together a proposal that is has the core features, and to closely monitor it and make sure that we are somewhere in the savings category. So again, I might come out with my own estimate slightly lower savings than Bob and his group did, but that's okay.
Thank you, Jim. Those are always savings after covering everybody with a much
That's
more
net
comprehensive
savings.
package.
You'll see an increase in cost because everyone's now covered and covered well, but you'll save even more from reduced administrative costs, lower drug prices, and potentially some additional savings about fraud detection and reduction and lower use of ineffective care.
Right. All right, so we're approaching the hour. We have a last question about if you could talk about how the Kaiser network of doctors and providers would be impacted. Would Kaiser still exist if we did single payer right? And how would the unionized workers at Kaiser and on the clinical side, in their networks and hospitals, how will they be impacted?
Yeah. So if it's up to me, yes, Kaiser would exist. I think Kaiser is very popular with large portions of the California population, and by important metrics does a very good job. And I would like to see the system set up to accommodate Kaiser. Now, there are certain things would have to change. Kaiser would, as you pointed out earlier, Michael, no longer control its capital investment. Current Kaiser management would not like that. Their model is entrepreneurial and involves deciding to build hospitals and bringing in income on the basis of that expansion. So that would have to change. Whether or not they were capitated or fee for service could be up for discussion. Again, I think both of those could work. I think with the right rules in place, a well-functioning HMO, not beholden to shareholders, could work fine. And Kaiser is the most famous example of that. And then the union people working for Kaiser would do perfectly well. I think that answers the question.
Yeah, essentially, we're getting rid of the Kaiser Health Plan and maintaining the clinical operations without their, I think you well put it, entrepreneurial approach, right? All right, I think we are at the end of the hour, and Jim, if it's okay with you, we will make this available to folks who couldn't participate, and really appreciate you taking the time. I mean, this is a very accessible seminar, graduate level, in health policy and economics. So thank you so much for taking the time.
Thanks for inviting me. I love to talk to people interested in this. If there are other questions, Michael, you know how to reach me, and I'm happy to entertain those questions. Yeah, thanks again.
We'll have to have you back, right? This is maybe the first of a few, if we're lucky.
I hope so.
All right, great. Thank you. And Pilar, do you have any last words?
No, just look out for the email from us tomorrow morning about the events on the 31st. And thank you everybody for joining.
Can I just offer one marketing pitch?
Absolutely.
For anyone who doesn't know about it, Health Justice Monitor is the proud successor to Don McCann's quote of the day. Don is still, he was on the call. I don't see him at this moment.
He still is. He still is.
Great.
All right,
Don is happily still participating, but we have assembled some very clever people, David Himmelstein, Steffi Wohlhandler, Adam Gaffney, Egan Kemp, Allison Hoffman, and it's about 5 times a week. And if you're interested, go to healthjusticemonitoredorg and check out the website and sign up for the email.
Hear, hear. That is the best daily or near daily policy and very accessible policy source on the net. I think it's really great work you all are doing. And Don, you did it so well for so long. It's great you're still involved. All right. Thank you all. And we'll see you next time, and see you on July 31st.